We move on to our next talk. Small changes in IBank policies can have a huge impact on HCRP by Dr. Neeti Gupta. Neeti.
Thank you, Dr. Swati. Can you see my slides?
Yes.
Uh, yeah. So thank you for the opportunity. And I would be talking about the changes in the iBank policies, how they have impacted, like especially our model, which we have started in at AIMS Rishikesh. So the iBank model for India was given in 2010 by Dr. Rao and Sangwan et al. Of around one iBank over 20 million population for the collection of 2 lakh corneas. And this was the study published by Namrata Sharma et al. Where they studied around 12 best iBanks of India in 2013-14, and they saw that out of this 20,000 eyeballs collected, basically most of the iBanks were dependent more on voluntary donation, which has now improved over the years, and the whole globe was mainly the type of retrieval. MK media was the most common preservative media with a utilization rate of 50.5%. And most of the iBanks in the West, as well as in the most popular iBanks in India, have shown us that most corneal retrieval through HCRP was of optical grade tissue, and hospital corneal retrieval program is the way to go for the iBanks. And also, the similar thing has been shown by the RIEB iBank at Hyderabad, as well as Purva, the iBank in West Bengal, where they showed that when they started on the HCRP program, their collection as well as the quality of the tissues, they improved. So with this background, we started a iBank at AIMS Rishikesh, and AIMS Rishikesh is a 1,000-bedded multi-speciality hospital, and we collaborated with Hans Foundation as our financial collaborator and LV Prasad as the technical guidance. And they built a state-of-art iBank at AIMS Rishikesh, where we had all these facilities which are needed for a good iBank. And we got the HOTA on 20th August 2019, and we started functioning from 26th August 2019. So we had 4 counselors who were trained at LV Prasad, and they used to work 24/7 with our postgraduate ophthalmology residents. And we had 2 dedicated phone numbers to our iBank. And we also obtained a NOC for the MLC cases from the Superintendent of Police from Dehradun for the medical legal cases. So this is the overall performance of our iBank for 2 years and 2 months, as we could not work for around 10 months because AIMS was also a COVID facility. So we were not admitting other patients at our hospital. So we had to close the iBank during these waves of COVID. So during this year, we had collected 332 corneas, out of which 75% was from HCRP and 46% were MLC cases. And we did around 184 transplant, where mostly we were doing penetrating keratoplasties, and we distributed 34 corneas in the state of Uttarakhand with a total utilization rate of 53.11%. So I would divide this, like initially when we started the iBank, we had the policy of approaching all deaths. We adopted this policy of approaching all the cases, irrespective of whether they were contraindicated or useful, to use this opportunity for increasing awareness among the public, also sensitizing our hospital staff, as the iBank was very new in the hospital, and also to facilitate resident training program, as we could use the contraindicated cases for medical education. Also, we had a HCRP register at our iBank, which was maintained by the eye donation counselors. And the counselors, they used to write all the details of the deaths they were approaching, who informed them, then what was the reason, cause of death, in which ward or where they were, they went for the call, and what was the reason for not donating or donation when it happened. Then most of the cases we did in situ excision for all useful cases, and we used to retrieve eyeballs for contraindicated cases. Also, MK media was the main media for the utilization, and we were also using cortisol at that time. And more than 12 hours we were considering as time lapse if the body was not refrigerated. So in the pre-COVID era, that is the first 7 months of our working, we had collected 154 corneas 80% was HCRP, MLC was only 27%. And we did 76 transplant. We distributed 12 corneas in the state. So you can see the utilization rate of our eye bank was 39.6%. So we analyzed our work, and we had published this in IGO, and we found out the areas where we were weak. So during the analysis, we found out that around 12.63% of the deaths were just informed by the hospital staff. Although after so many awareness activities in the hospital, still our counselors used to get very less calls from the hospital staff, and they used to identify most of the death during the rounds. And so the counselors, they missed around 27% of the deaths. This we recorded from the hospital death record as well as from the HCRP record. So this was the time when COVID happened, and we from the hospital authorities, we came to know that all the deaths were informed to the security guards, and they had a WhatsApp group where they used to inform about the death. So we included our iBank counselors' name in that group so that they can get all the information about the death in the hospital. Then second thing, which was very interesting, was that around 46% of the cases were useful, which were counseled by the EDCs, and there were more contraindicated cases which were counseled by them. So since one of the performance indicators of the EDC is the number of the cases they counseled, on verbal communication with our counselors, we came to know that they were very stressed when they were counseling useful cases, as they were afraid that if the case does, if this is not converted into donation, then it would affect their performance. And when they were counseling contraindicated cases, they were very cool, and they were used to do it very nicely because they were not afraid of the outcome. So we changed our policy from approaching all cases to only approaching useful cases. Then the third thing, because of COVID, the guidelines had come, and so we were preserving all the corneal tissues in cornisol rather than in the MK media, or we were transferring from MK media once we got the reports. So the preservation time also increased to 14 days. Then death to preservation time also increased because all the bodies, since AIMS was the COVID facility, so all the bodies from the AIMS hospital were transferred to the mortuary, and our counselors were basically focusing on the mortuary. So for 24 hours, we could do the retrieval, and you can see that a major part of the corneas were more than 12 hours. And when we analyzed the optical quality of these tissue, we saw that 64% were of good quality, right? They were optical grade. So during the COVID, if we analyze the COVID data, then we saw that the number of eye donors were, the corneas which we collected during the COVID time was 178. And this was again, maximum was HCRP, but the major impact was that 65% of that was from the MLC cases. And we did transplant, most of them were therapeutic because we had to cater emergency surgeries during that time. And we distributed around 22 corneas still in the state to other corneal surgeons. And you can see that our utilization rate had increased to 66.29%. So when we compared this thing, that in the previous 7 months, we had 154 corneas. In the post-COVID 16 months, we had just 178 corneas. But the important thing is that we could get 65% from the medico-legal cases. And the cornea for medical research, or the corneas which we were discarding, had decreased because we were approaching only useful cases. So the utilization rate increased to 66.29%. So to conclude, that while it is easy to start an eye bank, it is essential to be aware of the trends and challenges one faces after the eye bank is set up. And the challenges are many, but they can be overcome by proper implementation of the strategies. And we found out that approaching useful cases and also medico-legal cases, which is already known actually, is the key to increase the utilization. Thank you.